So much of this, many of you already know, and you've heard me speak in consultations about the way we think about drug therapies and why we give you what we give you. But I'm going to pretend we're not in a consultation and nobody knows anything, and talk about melanoma and how we manage it as a medical oncologist. So you all know pretty well the stages of melanoma. Most people in this room would know it. So stage 1 and 2 is where you just have the primary. We're talking about skin melanoma. What we're not talking about tonight is mucosal melanoma or ocular melanoma. So whenever you in the room with mucosal or ocular melanoma, this is really just about skin melanoma. And what we're learning in skin melanoma, we're trying to apply to those other melanomas. But skin melanoma is the common melanoma. That's Australia's cancer. So stage 1 or 2 is where you have the first skin lesion. And this is Arnie Schwarzenegger. He actually had a primary melanoma many years ago now. Most of the melanoma we see in Australia is stage 1 or 2, and it's cured with surgery in the majority of patients. Stage 3 melanoma is where that first melanoma has spread to the local lymph nodes, as Richard and Robin have already explained. And then stage 4 melanoma is where it spreads around the body to distant sites like the bone, the liver, the lung. So all in all, the majority of people with melanoma in this country have stage 1 and 2 melanoma and are cured with surgery. And as Matthew said, I'm a medical oncologist, so I'm an oncologist, a cancer specialist, but I treat cancer with drugs. Unlike Robin, who's a surgical oncologist, she's also an oncologist, a cancer specialist, but she treats melanoma or cancer with the knife. There's also radiation oncologists who are specialist cancer radiation oncologists, but they treat cancer with ray beams. So I'm the medical oncologist, and so this is where I hang out. These are where my patients are. Although we've had such success here that we're now using it here, and that we're now doing trials in stage 2 with drug therapies. But that's my expertise, drug therapies. So tonight, I'm just going to focus on stage 3 and 4 melanoma. So updates on drug treatment. So this is what I'll try and cover. I better actually start my timer. Someone will tell me 15 minutes is up, actually 7:45, so I'll try and get through things. So first of all, the drug therapies. What are the drugs that are available? How do they work and how effective are they? What side effects can I expect? Will the immunotherapies stop working if I stop them? That is the most common question I get. And drugs for early stage resectable melanoma, so stage 3. And then lastly, we'll touch on the future. What's next? Because many of you in the room would have heard me say, I've got to keep my toolbox full for you. I've got to keep this full so that we always have a next option. Yes, I'm a hopeful oncologist, but I'm always thinking of the next step should we need to think about the next step. So what's next? Where's the future? So drug therapies, what drugs are available? So up until about 8 years ago, this is what we saw when we ever did a clinical trial. So I'm going to explain this because us oncologists see these curves all the time. These are called Kaplan-Meier survival curves. And this is a drug trial of 2 drugs, chemotherapy, DTIC, and then something we called biotherapy, biochemotherapy. And it was all the rage about 15 years ago. So at the beginning, everybody's alive, 100%. And this is time. And you can see that the curve drops down, and by 9 or just after 6 months, 50% of people have died. And that's what we call the median survival in this trial was only just over 6 months. As time goes by, it drops and it drops. There was absolutely no difference between the curves. So this magical thing called biochemotherapy did no better than just a single chemotherapy agent. And in fact, by 3 years, 36 months, less than 10% of people were alive. And decades, my senior medical oncologists, my mentors, did trial after trial after trial, and this is what it looked like. So you can imagine what it was like for patients and for doctors treating melanoma with drugs. It was just devastating. We've come a long way. So instead of having a 5-year survival for metastatic melanoma or stage 4 melanoma of 5%, it's now well over 50%. And these are trials that we actually started back in 2012. So who knows where we'll be in another 5 years. But that's our goal, is to improve that 50% with all the trials we are still conducting at Melanoma Institute. So it really was a lifeline that started back in about 2009. And as Richard showed you before, it was these targeted therapies and immunotherapies that have really altered the way we manage melanoma so that we're no longer seeing that dismal, dismal survival in stage 4 melanoma. So what I'm going to do is go through the mechanisms of action. And I'll step through it. I hope people don't sort of daze off, because I've tried to do it as simply as I can. I'm a simple person and I like to try and understand things in a very simple way. So first of all, targeted therapies. So let me simplify this. That olive line at the top is the cell membrane. This is a cell. This is a cartoon of a cell. The white part at the top is the outside of the cell. This is the inside of the cell, the light green, and this purple bit is the very special nucleus. That's where the genetic code of the cell sits, or you, or the human. And I've put 3 pathways there. This pathway is an important pathway. This is another one called the MAP kinase pathway, and this is just the cell cycle machinery. There are thousands of pathways in a cell, but why are these important? Number one, they're often overactivated in cancer, but these control the cell and its behaviour. A cell is very well controlled. It knows when to divide, it knows when to stop. But if you have a problem in any of these pathways, or any of these are all molecules, for example, the BRAF mutation, which is common in melanoma, it happens in 40% of melanomas, that pathway gets switched on and it constantly activates the nucleus to divide and divide and divide, and the cell is immortal and grows, and that is what is cancer. So 40% of melanomas have a BRAF mutation, and that is one of the leading causes of that cell to be immortal and to grow out of control. So targeted therapies target that abnormal gene. So BRAF inhibitors block that. Now, no other cells in the body except melanoma cancer cells have that abnormality. So it's very targeted, it's very specific, and only the melanoma cancer cells die. If you think of it like this is a highway, and it's a thief going down the highway and going into the nucleus, and you put a roadblock. So the police put one roadblock up. But sometimes thieves can be smart and get around that roadblock. So if we add in a MEK inhibitor, we get even better enhanced cell death, the cancer cell death. So that's what targeted therapies do, and that's why we call them targeted. They target the abnormality in the melanoma cancer cell and kill the cell. Now, immunotherapies, they're very, very different. So targeted therapies, they kill the cell directly. Immunotherapies are drugs, they do not kill the cancer cell directly. They get your immune system to do the work. And at the center of this are these T cells. In fact, there are many, many different cells in the immune system, and our focus in the last decade that's given us a lot of success is the T cell, but there are many other cells we're working on to try and activate to kill cancer. Now, all of us have T cells. They're very important. They kill viruses, they kill bacteria, and they're constant tug of war of being activated to kill the baddies and tolerant of self, because you don't want your T cells to look at your own body and kill parts of your own body that are healthy and normal. So everything on green on the outside of the cell are signals into the cell to tell the T cell to get activated, kill the enemy. Everything in red is a checkpoint, like checkpoint Charlie, that stops the T cell from becoming overactivated and makes it tolerant. And you want it to be tolerant of yourself. So these are some molecules. These are the signals into the T cell, and you'll recognise at the top of the red the checkpoints, PD-1 and CTLA-4. And we've had a lot of success by blocking the checkpoint. So taking away checkpoint Charlie to push the cell to get activated against the cancer. So the cancer drug, so the drugs, the anti-PD-1 or the anti-CTLA-4, so anti-PD-1 you would have known as pembrolizumab, Keytruda, or nivolumab, Opdivo, and anti-CTLA-4 is ipilimumab. These are breaks against the checkpoint to activate that T cell against the cancer. That's how they work. I hope that wasn't too complicated, but the important fact is these drugs don't kill the cancer cell directly. So let me show you one more cartoon to illustrate it. So this is CTLA-4, so this is ipilimumab. Pretend this blue cell is one of your immune cells. It's called an antigen-presenting cell. Forget the name, but it's an immune cell in your body. And it's constantly surveying for enemies, virus, bacteria. It comes across melanoma, so it gobbles it up, and then it spits out a piece of the melanoma. And it shows it to another immune cell, your T cell in your body. So the T cell goes and shakes hands with this bit of melanoma, and it's trying to work out whether it's a friend and should leave it alone, or whether it's an enemy. So if the other immune cell says to the T cell, hey, I'm going to bind here, the T cell goes, oh no, that's a friend, but leave it alone. And then the melanoma can flourish because your immune system thinks that it's self, that it's okay, that it's a friend. However, if ipilimumab gets in there and stops that handshake, that second handshake, the T cell gets activated and can kill the cancer. So PD-1 is a little bit different. Pretend now the T cells have been activated in the periphery and they now go down to the tumour mass. So the T cell's activated, it comes to the tumour mass, this is melanoma, and the melanoma is smart. It can put up this thing called PD-L1. And so if the T cell comes in to kill, but the melanoma puts up this defence, it switches off the T cell and the T cell won't do the killing. But if you get something like pembrolizumab or nivolumab in there and stops that handshake, the T cell can kill the melanoma. So that's sort of a basic way to explain how it works. When we put them together, it's even more effective. Why is that? Because at the periphery, when your immune system first meets melanoma, it allows the T cell to get activated. The army then builds and goes to the masses, and then the PD-1 enhances that effect. So the two drugs together are even more effective than one alone, but not everyone needs two drugs. Some people just need the PD-1, some people just need the ipilimumab. And there are things that tell us when we need to go in with the two drugs together. So brain metastases are a good example. So when melanoma is spread to the brain, that's a good example of when we know we need to give two drugs together. This is one of my patients who had 3 brain metastases. You can see on the top row in the brain. These are scans of the brain. So that where the arrows are, these are brain melanoma. At week 18, he had a complete response, and at 4 years, he's still got an ongoing complete response. The reason we know we need to give two drugs together is a trial that we conducted and wrote here. And this is where in the yellow, this is again one of those Kaplan-Meier curves. You start with 100% and then you see in time. Now this is not overall survival, this is progression-free survival. So that's a little bit different, I'll explain in a minute. But the yellow is when you put the two drugs together, and the blue is with one drug, nivolumab alone. And in time, this is the progression-free survival in the brain. We can see that most of the progression occurs in the first 6 months, and by 12 months, we know that 56% of the people with melanoma in the brain have not had progression in their brain with these drug therapies, and it more or less stays flat over time. So this is the trial that told us that people who have melanoma in the brain, we have to try and give the two drugs together. It's much more effective than one drug. So I'm just going to touch on side effects. What side effects can I expect? I'm not going to delve too much into targeted therapy. That's the BRAF mutant melanoma. The side effects with targeted therapies, the good news is you stop the tablet drugs, they're tablets, and the side effects disappear, the main side effect being fever. So they're actually, it's difficult to manage, but easy because you just stop the drug and the side effect goes away. However, it's quite frequent. Immunotherapy is really, these are the side effects we have to be concerned about because they're about switching the immune system on too much, and so that your own immune system starts to attack your normal tissue. Fatigue is actually a common side effect, although that is not an autoimmune. It happens in about 20 to 30% of people. Skin side effects are quite common. Many of you may know about or have the vitiligo. So this is where your own immune system attacks the pigment cells on your skin so that you lose colour in your skin. Let me just push this there. Sometimes you lose colour in your eyelashes, in your hair, because your own immune system attacks the pigment in the hair follicle. And you can also get a rash. This is quite a severe rash, but these thick sort of itchy plaques that come and go. It can be patchy or confluent, but that's a good example of a rash you can get with PD-1. Sometimes you can get diarrhea. I've given the frequencies here for monotherapy with just anti-PD-1. If you put the two drugs together like I showed you before, the frequency goes up about 2 or 3-fold and they're much more severe. So diarrhea is quite common, as is a thyroid problems, low activity of the thyroid. Your pituitary, it's not in the brain, it sits just below the brain. It's the master hormone controller. It can stop working as well. And then there are more rare side effects. Kidney, a lung can become inflamed from our drugs. The nerves can be attacked. The eyes can be attacked. The liver can be attacked. In fact, any organ in the body can actually be attacked by your own immune system with these drug therapies, although they're much rarer. These are the most common, and the nerves are very rare. I just wanted to point one thing out. This looks a bit like it's got too much information in it, but it really doesn't. These are the rates of side effects for Keytruda and Opdivo, or pembrolizumab and nivolumab. Blue are the total rate of toxicities, red are the more severe toxicities, and green are those who have to stop drug due to a toxicity. So this is PD-1. These are both PD-1 drugs. This is ipilimumab alone. You can see that it's much higher. And this is the dabrafenib and trametinib. These are the targeted therapies. Now, one thing you have to remember is if any of these side effects occur, you just stop the drugs, they go away. Not so with the immunotherapies. But I'm just going to show you that placebo actually has a side effect rate. So these are the placebo arms from our stage 3 studies. You can see that more than 60 or 60% of patients will get some form of side effect that the doctor has attributed to the immunotherapy, because if you've got someone on immunotherapy for a year, they will get a cough or a cold, and you may attribute that to the drug therapy. So what the point is that given that that's placebo, you can actually see how well tolerated these drugs really are in the big scheme of things. So they're very well tolerated for cancer treatments. Although some of the side effects can be scary, they're not actually that frequent. In fact, they're so well tolerated. One of my colleagues, Alex Menzies here, he's treated probably the oldest patient in the world, I think. This gentleman had 2 or 3 doses of anti-PD-1 at 101, and I think he's about to have his 103rd birthday. So that just tells you how well tolerated the drug can be if you're willing to give it to someone who's 101. So will the immunotherapy stop working if I stop them? I'm going to be quick so that we get to the end. Just some data. I have mentioned this to some people that I see in my clinics. This is a retrospective study. Each line is a single patient, and we've categorised them, this was international, by how well they did on their CAT scan. So at the top, these are people who had stable disease. These are people who stopped early. Normally we treat for 2 years. They stopped early, and they stopped early not because of a side effect, they just wanted to stop. So the people with stable disease are at the top. In the middle, in yellow, are the people with partial response, so good shrinkage. And the large group at the bottom are the people who had a complete response, so complete disappearance of their melanoma. Of the stable disease, you'll note the black, by the way, is the time they're on treatment. Blue is just follow-up. The little arrows mean they're still doing well. And this is weeks at the bottom. So what you can see is these people are stopping early. On average, they're stopping at 9 months or less, on average. So this is not typically what we do in clinic, but just to give you a bit of an idea. So of the people with stable disease, only 1 of the 20 relapsed, and they actually regrettably died due to progression in the brain. People with partial response, there were 46 in this study. 2 had a relapse. 1 was re-challenged and had stable disease and is fine. The other died due to unrelated reasons, did not die from melanoma. Of the complete responders, 115, 6 relapsed, 3 were re-challenged and responded. One had surgery and didn't require any drug therapy, is doing well. One died due to unrelated causes, not melanoma, and there was only one that died due to melanoma that had progressed. So what this means in the clinic, and what we've been doing anyway, is we generally like to treat to 2 years. If you've had a complete response, we may consider earlier if you want to stop. And generally, people who've had a complete response do very well, and the majority of people will respond again to their drug therapy if they stop. I'm just putting this up here because that's one of the most common questions I get from my patients. The other thing we do is a PET scan. This is unique to MIA. We'll always do a yearly PET scan for our stage 4 patients who are on immunotherapy. And what we've shown is that if you have what we call a complete metabolic response, no matter what your CT scan shows, even if you can see what we call scar tissue on your CT, if you have a complete metabolic response, you are likely to do very well long term. Over 90% of people are fine and well in time. So that's a good marker. So much so that if you compare people who have had what we call a partial response on their CT, and you can still see lumps on the CT, but they do not have any uptake on their PET scan, they're the blue curve. They do very well and do not recur. These are not survival curves, these are recurrence or progression curves. They do very well. So that's why you'll always often get your yearly PET scan, and we talk about how a good thing it is when we see a complete metabolic response. I'm not going to touch on this because we're running out of time, except to say what adjuvant therapy is in stage 3. This is stage 3 melanoma, where you have your surgery and then we give mop-up therapy just for 12 months. And what that basically does, these are the 3 major trials, which have shown that if you just give 12 months of treatment to stage 3, people with stage 3 melanoma, that reduces your chance of the melanoma coming back by 50%. So what I mean by this is if you have stage 3B melanoma, the surgeon, Robin, has removed all the melanoma, your scan is clear, you have no evidence of disease, your chance of the melanoma coming back is around 4 in 10 in the next 5 years. But if we give 12 months of drug therapy, either targeted or immuno, we can reduce that to only 2 in 10. It's not completely eradicates your risk, but it markedly reduces by a half, 4 to 2. If you have 3C melanoma that's removed and your chance is 60%, the melanoma will come back in the next 5 years, we can reduce that again by half to 30%, so it's only 3 in 10. So that's the concept of mop-up adjuvant therapy. It's very different to what I was talking before about metastatic melanoma. And as Robin explained, we're very excited about what we're seeing in neoadjuvant, where we give the drug first in stage 3 that is surgically resectable, and then we cut out the remaining lymph node, and then Richard tells us whether the patient has had a complete response or not. And the great thing about this is you get feedback as a patient. You know whether you've responded or not. And if not, we can then alter the treatment at this point to try and enhance your chance of the melanoma not recurring. I won't go through this, but it's just showing you how great it is when you have a complete pathological response. So just briefly, what about the future? Because I think that's really important. I think about the immune system in very easy steps, and then I look at the drugs we're working in our trials to try and cover all those steps. So if we want our immune system to eradicate cancer, we first want our immune system to recognize cancer as foreign. So that's called recognizing the tumor as an enemy. We then want to activate an army against that tumor. We then need to move that army to the tumor, and then we need the immune system to actually kill the tumor. And at the moment, we have trials with almost all of these molecules at every step of the way. And you can see that there is a plethora of combinations that you could possibly put together. And it's in our laboratory that Richard was talking about earlier that we're trying to match the best combinations of immune therapies for patients by looking at their tissue, which they've generously banked with us so that we can do this research. We have a clinical trials app. It's mainly for health professionals, but it's free and downloadable where people can look up clinical trials that are open. If we're only about to open the trial, like it's about to open a week, it will not be on the app. We only put things that are actually open on the app. And just to show you our biggest focus, are those who do not respond to any treatment. And this is just a small cohort. We have several of these cohorts that we're exploring in different ways. 34 patients, some who had no response to combination immunotherapy, some that had no response to PD-1, and we're looking at what other targets we could use for drug therapy that may work in these patients, and that's the matched immunotherapy program that we're using the Melanoma March funds for at the moment. And lastly, microbiome, this is my very last slide. Very exciting work that shows bacterial diversity in your guts is really important, or is associated, we should say, associated with response versus non-response to immune therapy. This is to doublet immune therapy. So these are all the responders. These are the non-responders. The responders have a lot more higher diversity in their gut. If you look at toxicity, this is high-grade toxicity. This is no toxicity. Again, no toxicity, much higher diversity of microbiome in the gut. These are only associations at this stage. Our next step are to do dietary interventions to see how we can change the microbiome. If you have a good response and no toxicity versus no response and high toxicity, there's a very big difference in the microbiome diversity. So we're at the stages of working out what these patients' diets were and correlate it with that diversity and see if we can come up with an intervention. So with that, I'd like to thank you for your attention. I'm sorry I went over time, and particularly the patients and their families who've participated in any of the work that we're doing at the Institute in our trials and our banking to try and solve this problem and achieve 0 deaths from melanoma. So thank you.